Integrated Care Board's clinical lead for urgent care. So I'll be supporting the presentation and any questions through the morning, and I'll hand you over to Rachel, who'll do most of the hard work today, I'm afraid.
Good morning, everybody. I'm Rachel Maiden. I'm a commissioning manager in the Derby and Derbyshire Integrated Care Board, and I work in the urgent and emergency care team. Could we have the next slide, please? Thanks, Nikki. So we're going to just talk to you a little bit about the review that we've started to do around community urgent care and same-day care across Derby and Derbyshire. So what is community urgent and same-day care? When we talk about that, we're talking about health services that give you quick same-day access, but in the community. So quite often that will be something that's much closer to home. People often think about urgent care and they'll think about A&E, but what we're talking about today are those services that are in the community closer to you. So that might include things like accessing appointments at your GP surgery. It could be one of the community urgent treatment centres that we have in the county, and we've currently got 5 of those, one in Derby City and then 4 others in Ilkeston, Ripley, Whitworth in Matlock and Buxton. It could mean something like an appointment or an attendance at a GP out of hours walk-in service. Now we have GP out of hours services across the county, but 3 of the sites have a facility for walk-in services, so patients can turn up at certain times to be seen on the same day, and that's Swadlincote, Ashbourne and New Mills. And it could also include going to your community pharmacy. So you may or may not be aware of the Pharmacy First programme, which now means that pharmacists can see people on the same day for a number of conditions and treatments. There are other things, obviously, that happen within that bracket of community urgent care, but those are some of the examples just to give those to you today. So why did we decide we needed to start this review? We started to look at our community urgent treatment centres a little while ago and felt that actually we couldn't look at those in isolation. We need to have to look at the urgent care across the services as a whole, so that a wider view. Now, I think we all know services are under increasing pressure. We know that certain communities in Derby don't have the same access to services as others. I've listed, for instance, the urgent treatment centres are in certain parts of the county, and whilst everybody in the county can access those, it does mean that there are some people would have to travel further, and that's particularly in some of the more rural areas where public transport might be more difficult. We know that people face long waits when they're trying to get to services, and there can be confusion about where to go. And so that makes it difficult for people to get the right care in the right time. So we wanted to look at the services, and we want to have to understand what's working, what's not working, and how we can do it better. Thanks, Nikki. So what have we done so far? So far, we've mapped out the current services. That means looked at what's already there and looked at how they're being used. So we've also looked at our population data so that we know more about who's using the services in each area, what the deprivation levels are in different areas, and how much our populations might grow in the next 10 or more years. And we're now starting to have conversations, early conversations, as Hannah said at the start. This is very much the start of the process. We're having conversations with our primary care networks in each area to understand a little bit more about the local picture. So the information that we've pulled together so far has been across Derby and Derbyshire as a whole, and now we need to understand a little bit more about each of those communities because they're all different. Primary care networks are groups of GP surgeries in different areas who work together to provide services for their populations. Thanks, Nikki. And what have we learned from that information? So we spent time gathering data about how people use the services, where the services are based, and we've also had some feedback from an online survey about how people use urgent care services. And I don't think any of this will come as a surprise to you, but what we've learned is that services are not evenly distributed, and we can see gaps, particularly in areas where there are higher deprivation levels. A lot of patients are struggling to access GP appointments on the day or other urgent care services promptly when they need it. And feedback from patients so far from the public has shown us that there are, as I said before, the long waits and that confusion. and there can be unclear service information. Thank you. So what we need to know more about from you. So we need to know a little bit more about individual communities, and we need to know what you think we should be considering, what is important to people in communities when we're accessing the urgent care. So it could include things like access to services, where they are, public transport routes. It could be what services are available nearby and whether those are the right ones for each population. Each of our 8 populations in Derbyshire are very different and have very different needs, and it might be that there are different things that are required for each population. And one of the things that we need to know about local communities is if there are local services that we might not know about. So we predominantly think about healthcare services when we're talking about urgent care. There might be other things that you feel contribute to the community urgent care system. It might be something completely different to those, but those are some of the suggestions, but we'd like to hear what you think. Thanks, Nikki. So for our next Slido then, we'd like to ask you, what else do we need to know more about when we're starting to look at community urgent care services? What do you think is important and make sure that we are considering as part of this process? So I will just wait for a moment and I'll let people start to type in. Yeah, transport, I think, is going to be a major issue. I think that we will need to consider. That's a really good point. Patient education, yeah, transport and parking again. As Hannah said at the start, we will pull all of these things together. We will incorporate them into the conversations that we're having. And further on in the presentation, I'll explain to you a little bit more about our plans to consult more widely as we move through. So this is very helpful. Thank you. Lots of things. Thank you. This is going to be a wealth of information for us to look through. Okay. I'm not going to be able to respond to all of the questions that are within this as part of the presentation, but we will have the question and answer session. And as Hannah said at the start, we will make sure that we respond to everything that's raised at some point, whether that's during the session today or afterwards, and make sure that's shared with everybody. So please do keep the information coming. That's really helpful. I think at that point, please do feel free to keep typing, but I'm going to move the presentation on just so that we can stick to time. I think we should have a question and answer session before we go on to the future session. So I think Paul is going to come in at this point and answer any questions that might be raised. If anybody has anything they'd like to ask.
So I think the first question I can see specifically is the PPG in Amber Valley, and will you consult us? So I think there's a process of engagement that's occurring, and this is part of that. And I think engaging with the PPGs is also part of the process that is likely to occur over the succeeding 6, 12, 18 months. I don't think there's a sort of one-off process to consult with every PPG, but we certainly welcome a connection on issues. So in terms of, I'm seeing different questions coming through, really. It depends what you mean by enable same-day treatment. I think we've got to have a kind of overall sense of what's being delivered on the same day across the county. So if you're sort of looking at numbers per se, that is occurring across a month in Derbyshire, Derby and Derbyshire, you've got between Monday and Friday about 550,000 GP appointments. So that's over 500,000 appointments. And that means that every other person in Derbyshire has been seen by their general practice each month. And in terms of the people that are seen on the same day, 40% of those appointments, that's approximately 220,000 patients across the month, are seen on the same day. So there's a considerable volume of work occurring in the general practice arena, and some of that will be, assessments, treatments, and such like. In terms of urgent treatment centres, which is where this first review sort of started, they cover a mix of services. So they cover patients being seen for minor injuries, and that will include treatment for those conditions, as well as increasingly minor illnesses, and a lot of illnesses that traditionally would have been seen in general practice. And so across Derbyshire, there's probably about 500 appointments a day going on through the urgent treatment centres, and then there's additional appointments occurring, which do include some treatments from your pharmacy first. So there's a whole spectrum of same-day work occurring. So I don't know if that just sort of lays a picture really about what is being offered, not just the sites, but the sort of volume of work that's occurring. I don't know if someone can help with the sort of feeding questions, because I'm seeing different ones. But in terms of the connection between ED and 111, it's a 111 is sort of an overarching service that anybody can access, and that does include the ability to access that online as well, and that can offer appointments in terms of directing people to the right service, and it can also provide appointments, what are called dispositions, into UTCs and into the emergency departments as well. There is obviously sometimes a mix of then if you are sent an appointment to the emergency department, where you end up in, that is up to that department in the end to find the best position for you there. So Katie, you've got your hand up.
Yes, I just wanted to help because there's been a few questions in the chat function as well, Paul. So
Yeah.
Lisa Grayson raises a good point around, will this include care at home? So naming services such as home visiting, rapid response nursing and therapy, and the enhanced falls recovery service as well.
Not specifically. There is an ongoing sort of community transformation work going on, which is building and connecting all those services. So we're very much specifically focused on the same day access to general practice, UTCs and pharmacy first. But that strand of work is very much in ongoing and being delivered by other parts of the ICB and organisations.
Great. And then there are a few questions coming in around services over bank holidays and weekend access and same day urgent care. So thank you, Sharon Dawson, for that one. And then Pete Stedman, who I think Christopher Potts, thank you, answered, of how do I access GP out of hours services in my location? So that has been answered within the chat. But there are some good questions around transport and also around access for hard to reach communities and disabled people as well?
Yeah, so I think there's comments about access to not having online access. That obviously then you can utilize 111 on the telephone that can offer you appointments through that. And there is also walk-in access to the community UTCs during their working hours. So that gives people who struggle with access, and using telephones, the ability to actually get to a UTC itself. I think the issue of access for people with disability, I think is in a sense the same issue for all appointments, and it depends on the disability, and it depends on what their sort of personal situation is, and you would think about it in terms of how those patients and individuals access current GP services. A lot of people with disability will access GP services and can also access the out of the urgent treatment centres and their local pharmacies too. So there are different ways, and I don't think there's a sort of specific answer that you can give on that. So there's a latest question about any provisions for mental health trained specialists in ED. That discussion is not specific to this area of work, the same day access. Suffice to say that because we're talking about community provision of same day care, but in terms of access to mental health specialists in ED, there are services that reach into the emergency department for patients who have got mental health issues. And obviously through 111, there is also access to a mental health helpline with an ability through that to access mental health support for crisis. So there are different ways into accessing care. So in the community, that would likely be through 111 and the mental health access line that works through that. Is there anything else on people's minds? Katie, just navigate me if possible.
No problem. I'm trying to keep up with Slido because there's some brilliant comments coming through and questions, so thank you. How much priority will be given to those areas that don't have any urgent care currently, e.g. swaddling coat is one of the questions that's come through.
So I think this sort of leads us to the next stage of the conversation as to where should we prioritise our thinking. So the capacity of the urgent care team and the ICB is such that it can't cover all parts of Derbyshire at the same level and same rate. And so we will need to just think more assertively about parts of Derbyshire, and that's partly why we're wanting to hear your views, because obviously you live in all parts of Derbyshire, as we can see from the Slido. So what your experience is and how that feels and looks from where you live. And it also is supported by the data pack that Rachel referred to earlier in the conversation about looking at where the current services are, where the current population is accessing those services, and what the population is going to look like in 5 or 10 years. So obviously the population will look different, not only in size, but also in age. And consequently, it's important to kind of try to think about how you future-proof services and how you provide for communities and populations going forward. So I think in direct answer to places without UTCs, there's going to be a question of how can you aggregate and integrate the current services into a more effective, more accessible offer for the population in those areas, and that solution may be different. So part of what the next phase of the work that we're doing, which Rachel alluded to, was talking with each of the PCN groups in different parts of Derbyshire and actually just trying to understand their perspective. And obviously, Swadlincote and South Derbyshire has a growing population. It doesn't have a UTC. Patients are accessing services in different ways, you know, across to Leicestershire, across to the city of Derby, across to Burton. And there may well be a need to think about how you integrate and transform services for Swadlincote, for North East Derbyshire, another area. But the solutions aren't probably the same because the population and the geography of each place is slightly different. Rachel, do you want to come in?
I was just going to say that I think that's probably a perfect place for us to move on to the next section of the presentation, Paul, if that's all right, because otherwise you'll do me out of a job.
All right.
Thank you very much for answering those. So Paul has just done a brilliant summary of where we are and what we're going to be doing in the next stage of the work and how we're going to start looking at where we focus our efforts initially. And because this is going to be such a big job, it is going to be a phased approach. So if we go to the next slide, please, Nikki. So looking at community urgent care services, thinking how they might work better in the future is going to be a very big piece of work. We can't do it all at once. So, you know, we saw that map of Derbyshire at the beginning. We know it's a very large county, a large population to consider. So we're going to do this work in manageable chunks. And to do that, we have to prioritise where we start the work. The work will be done in different phases. We will get to every place in Derbyshire. It just might be that that's a longer wait before we get to some areas. Now, we are going to be doing two work streams here. So we're going to be looking at how we might integrate existing services better so that patients can move between services and access things more easily. And we'll also be doing a transformation programme. The integration can start quite quickly and might happen in all or most areas fairly soon, but the transformation, and that's the bit that might lead to potential change, will be done in a phased process. So we've got 8 place areas across Derby and Derbyshire, and we're going to look at the same information for all of those areas to help us make a fair decision about where we start the work. Next slide, please, Nikki. So these are our 8 place areas, and you saw this map at the beginning when we were looking at where everybody had come from. When we say place, we mean a specific community in Derby and Derbyshire where commissioners like myself and my team, community service providers, local authorities, primary care, voluntary and community sector and the public all work together to meet the needs of the local population. And as I've said already, each of our 8 place areas in Derbyshire is very different and has different population need. So therefore, we don't want to put a one-size-fits-all process in or system in place. That won't work for all our populations. And we need to have those conversations to understand exactly what is needed in each place. Thanks, Nikki. So how are we going to prioritise? So to help the Integrated Care Board prioritise where we begin, we're looking at a lot of different information. I've already mentioned some of these things, but just to recap. So we are looking at population size. We are aware that there are certain areas of Derbyshire that are likely to grow in size more significantly than others in the next 10 to 15 years. We also know that some areas have higher levels of deprivation, and I noticed that someone had put in the chat about, so the place areas may not have a particularly high deprivation rate overall, but there are pockets of deprivation within those areas, and we will be considering that as part of this process. We're also looking at what services are already in place, whether they are the right ones in each population. Do we need to think about how those could work differently and what those population needs suggest that we should have? Thanks, Nikki. So our next question to you is, do you agree with the things that we're looking at in terms of prioritising where we start, but what other things should we take into account to help us prioritise where we start the work? And when I say start the work, what I mean is start to have conversations in local communities that would involve people. So we will be doing engagement as part of that process. What do you think we need to consider to help us decide where we begin? I'll just give a moment for people to type. Certainly one of the things that we're looking at or have looked at the moment is admissions and also activity in different services, so we can see which areas are accessing and using services more than others. So I think the system confusion is a key point. Thank you. We are looking at where people are going to access services outside of the Derbyshire boundaries as well. So that is a part of the review and the work that we're doing. Yeah, bringing together the local ideas, and that's a key part of what we want to do in the next stage. It's really helpful. Thank you. Again, we will have another question and answer session towards the end of the meeting, so I won't respond to all of these directly. A lot of these are things that we're starting to think about already, so it's really reassuring to see that you're kind of backing us up on some of our thinking. Lovely. Please keep typing. I think we'll move on to the next slide, but we will gather all of this information together at the end. Thank you. So we're going to continue to have the conversations around prioritisation and where we start. And once a decision has been made, we will pull together the information around the prioritisation. I should just explain first, and we will take that to I'll take a recommendation about where we think we should start the work, and that will be agreed within the Integrated Care Board. That will be communicated out so that people understand where we're starting and why we've made the decisions that we make. And again, to reassure that it won't just mean that we're only looking at one area and not looking at other areas. We will look at all of Derbyshire eventually, but because of capacity within the system, it is just going to be a phased process. So once we've just made that decision about where we start, we will start to have much more detailed conversations within those individual areas. We'll be looking at a lot more data, considering where patients go to access care. And as someone pointed out on the previous slide, that might well be that people are going over the Derbyshire boundaries and into other services in, say, Nottinghamshire or Sheffield or Manchester. And we will consider that within those conversations. And we'll be looking at individual population needs for the future. So I mentioned earlier, we'd be looking at a programme of integration, and that's looking at how the services that we have in communities already can work together better. We know that sometimes these services don't talk to each other as effectively as they could, and patients sometimes get bounced around the system. So we will be looking at integration and how patient flow between services can be improved. And we will develop a bespoke engagement plan so that we're involving our local partners and communities in each area. And I know people have referred to in the chat and on Slido to different ways that we can communicate with you and engage with you in part of this process, and we will look at each area and what is the best way to engage in each area. So again, it won't be a single size fits all. We will look how we can do that to fit the needs of the community. When we're starting to pull together potential models of care for community urgent care in each area, you will be a part of that conversation, but those models are likely to vary based on the conversations we'll have. and we haven't developed any of those ideas yet. This is the starting point of the conversation to let you know we're going to begin that work and we'd like you to be involved. Thanks, Nikki. And I think somehow I've managed to rattle through the session far faster than we promised you we would, I'm afraid, but there is more time for questions. Our next question to you is there anything particularly that stands out to you from today's session? Have you any thoughts you'd like to share with us about what we've said so far? And again, I'll give you a couple of minutes just to start typing, and we'll move to the next question and answer. Just responding to one of the comments about the recording. The recording will be available on the Joined Up Care Derbyshire online engagement platform. So that will be uploaded onto that site later so that people can rewatch it. I think the link to that has previously gone out and has been put into the chat, and we can share that again at the end. In terms of timescales, we haven't talked about timescales yet, and obviously that's going to depend very much on where we start the work and what the conversations lead to. Some areas may have fairly simple, for want of a better word, solutions to how we can improve urgent care in the community. Others might be more complex, and that will obviously have an impact on the timescales. I think the question about the financial climate is a really good one, and it's really important to set people's expectations and to say, no, there is no new money for investment. We are going to be looking at what we currently spend on urgent care within Derby and Derbyshire ICB and how we can use that to best effect to make sure that we get the best services for all of our populations. But it won't be about new investment. Katie.
Yeah, there's a good question in the chat around will we be looking at research reports and recent projects to avoid duplication and repetitive work. So I think it feeds into the part that you said, Rachel, about looking at what is already in communities, but potentially what's planned and the research around it.
And we do also look at what systems are available in some of our neighbouring integrated care board areas, so that we know, for instance, Nottinghamshire and Leicestershire, how their systems work, whether those sorts of systems might be applicable to our populations. So we do look more widely than just Derbyshire as well to see what else is out there. Okay, I think I'm going to move on to the next slide, please. But please, again, keep sending your comments in. As we said earlier, the best way to stay involved at this stage is through the Joined Up Care Derbyshire online engagement platform. We'll share that link widely. There is facility to ask questions on that site, and you'll be able to watch back the recording from today's session. As we move forward and start to make any steps forward in the process, we will make sure that's updated on there so that you know what we're up to. And as we make a decision around prioritisation and where we start, we will be coming and getting more involved in our local communities to make sure that your voice is heard. I think Hannah's just shared the link to that platform in the chat. Thank you, Hannah. Yeah, so we will be doing the wider engagement, and that will go on throughout the duration of the project. Okay, thanks, Nikki. And so I think we're back to questions and answers again. So I'm going to look to Paul and Katie to help answer some of those. please feel free, if anybody does have a question and feels that they'd like to speak and you want to put your hand up, please feel free to do that. Otherwise, through Slido or in the chat is great. Thank you. I think the workforce question there, Paul, is quite a key one. That's going to be a big issue, isn't it?
So I think, yes, workforce is important. I think we sort of have to sort of put a bit of a context around it and just sort of think about what the sort of national steer is. And you will have heard quite a lot of this, but the three big shifts that the current government is trying to look through, which is what's called left shift from hospital to community and from analog to digital and from treatment to prevention. And so this sort of forms part of the broader thinking about how do you support communities and how do you give resilience to the care within communities. And part of that will be around what the workforce is, and that means all sorts of things. So what is the model of the clinicians that you put into the UTCs? What is the same day offer of clinicians and nurses and advanced practitioners that are fronting up your surgery offer on the day as well? And so I think it's important that in this discussion we kind of think about a whole range of things, including the different needs of different groups of patients in the community. So a lot of folk, and this is why this piece of work is very much being worked with the general practice and primary care colleagues, because there's as we've said in the findings of the data, an awful lot of demand, and some of that is people who need something on the day for a simple problem and don't need ongoing or complex care. And so it's trying to look at that population and how they can best be supported by services in their community, whether it's the pharmacist or the GP front door offer, same day offer, or whether it's UTCs. And so that you will need a different workforce. I think that question specifically around workforce might relate to some of the workforce difficulties that there have been in one of the UTCs in Derbyshire, and that's been worked through, and progress has been made on that. And now all the UTCs are staffed and open for business in against the specification. I can see a hand up. I think it's Keith. Do you want to offer your question, Keith?
Thanks, Paul. Good to see you again. Can you hear me?
Yep.
Okay, just to wonder about the closure of NHS England and the loss of jobs. Is that going to impact on the work you're trying to do?
Not specifically. I think the sort of position about NHS England is a moving feast currently, and I don't think it's been fully determined where all the functions will go. And quite a lot of the people and functions will go back into the Department of Health itself. Yeah. There will be some loss of jobs and roles there. I think the more notable issues are possibly changes within the ICBs, which cover, so we currently have an ICB, Integrated Care Board, that covers Derby and Derbyshire. And there is a move to reduce the size of those and to aggregate those. So it is possible that there will be some pressure on the delivery of these sort of projects. But I think for the provision of healthcare, these are the sort of projects that need to be focused on. And the function of the emerging ICBs is what's called strategic commissioning, so thinking at scale about what the provision of care should be. And this is exactly that, isn't it? We are trying to look at Derby and Derbyshire and say, we've got this now, we've got a different population in 5 or 10 years' time. We've got services which aren't equitable. How do we actually try and do that better for the population? So I think from whatever change is occurring, there should still be some focus on this sort of work. Does that answer your question, Keith?
Yes, thank you. Can you hear me?
Yeah.
Yeah, yes, it does indeed. Thank you. That's very helpful. As this whole call has been, by the way, it's extremely good.
Thank you. Katie, you've got your hand up at all?
Yeah, just some comments and questions coming in the chat. I think there's a couple around how we're going to share and spread the information from today and beyond that isn't just in a digital or online platform. So I'm sure we'll be able to answer that through Hannah potentially. Did you want to?
Yeah, that's fine, Katie. Yeah, so in terms of, like we've said, initially we've got the online engagement platform, but as any changes are identified, we will be developing bespoke engagement plans, which will include face-to-face elements as well. So but we'll be reaching out to people in various different ways. This is just the start at the moment, and we just felt that this session to have 3 teams would be the easiest to pull everybody together initially. But yes, there will definitely be various different ways that we'll be keeping people updated on this work and involved going forward as well.
Thank you, Hannah. That's great. And then there's one around, which I think you've answered that in terms of getting peer groups and patients involved further into the conversation. So that's really helpful as well.
Yeah, like I say, yeah, it's the very start. So like I say, when changes are identified, each change will have its own bespoke engagement plan. So there'll be plenty of opportunities.
Rachel?
I just wanted to add a little bit to that because I noticed there was a comment earlier from someone about the information that had been shared today and whether it could be shared beyond this call. And the answer to that is yes, this is not a confidential call. Please do feel free to have those conversations with people and to share the link to the online engagement platform if that's appropriate for that person, or if you want to feedback on their behalf. We are open to further comments from people. And I think Hannah said at the start as well, Slido will remain open until next week as well. So there should be lots of opportunity for people.
John, you've got your hand up.
Yeah. What sort of role does Healthwatch play in this whole process?
I mean, Healthwatch are kept aware and are connected through Hannah to this, and I think it needs to be emphasised that we're very sort of early in the process here, and I think Healthwatch can become more kind of connected as we perhaps get to the sort of more crunchy end of the discussions going forward. But I welcome views from Hannah on that as well.
Yeah, definitely. We link in very well, and we have good relationships with Healthwatch, both Healthwatch Derbyshire and Healthwatch Derby. So like I say, when we are starting to develop these bespoke engagement plans, we will be having early conversations with the local Healthwatchers as well to help us and support us in reaching out to local communities.
Thank you.
So we've still got a good amount of time. It's we've got the time. It's your time as well. So feel free to offer anything else, or if you've got a question in the chat which hasn't been answered, just please flag it up or put your hand up so we can get to it. Joe.
Hi, Joe Heaney. I'm from Derbyshire Mind. I've been trying to handle the technology and not doing a very good job, and I'm just looking at my own post and I got a typo in it, so I thought I'd just speak. So we Derbyshire Mind runs urgent care crisis services for people with mental health problems, specifically as designed as an intervention to alleviate statutory provision, inpatient, A&E, ambulance, and all the rest of it. And I'm still relatively new to the organisation, only been with Derbyshire Mind for since August, and what I'm seeing is a lack of use of the resource. I mean, the service is commissioned, and we are where we have been commissioned to be in areas such as Swaddling Coat, which of course is an area of quite high deprivation, Ripley and Buxton, and yet we know that statutory services 111 and the like are simply not signposting people into a resource that is already there. So use the resource. You don't need new money, but you have got a resource that is being underused because the local statutory services don't seem to know, the GPs don't seem to know, mental health teams don't seem to know, A&E crisis support. Those people, if they knew these services existed, you would have a much more effective crisis support service, and you'd have a service that you don't need any new money for.
I'm very grateful for your for you speaking up, and it's sort of so pleasing to hear that there's a service that has capacity and is underused in the current environment. So certainly there's been a lot of work done through 111 and Press 2, Star 2 to actually have crisis support. And I would have assumed through that they would also have had links with Derbyshire Mind. And I think there's been a theme throughout the call about patients not knowing what's out there, and also another layer that staff and services sometimes don't know what's out there. And one of the sort of underpinning elements of work that we are trying to do in Derbyshire is about how we connect people in the community to the right service for them in their place. And so that's quite a complicated piece of work involving both understanding the services, but also how you link them and how you transfer information and data between those services. And this is being thought about actively in terms of what are being built as navigation hubs, both across Derbyshire, so central navigation hub and also local navigation hubs. And they will, in the local navigation hubs, ideally have all the local detail and information about what the services are in their locality. And the intent and underpinning principle of that work is about no wrong door. So we can't expect any patient on any day when they're feeling pain or feeling a problem to know exactly where to go or be exactly the right destination, but that the services can signpost patients to the right place. And that might mean that services are slightly different from what the expectation has been in the past, so that simple care needs that can be dealt with by your pharmacist, you may be directed to your pharmacist, and that is within ways of care which are recognised, supported by evidence and appropriate, but means you may not be seen by your GP, or you may be directed to an urgent treatment centre because they've got an appointment there. So there's a lot of background work that sits behind the overarching piece around what is the same day urgent community access, and I think that there is grounds for hope that there can be improvement, but obviously there's a lot of work to do and lots of connecting to do in this work. So, any particular questions that people want to pull out of the chat or from the Slido that is perhaps worth covering at the moment?
Just having a look through for you, Paul. I think some have touched on what you've just been talking about, saying the first thing to concentrate on is improving the communication between healthcare providers and educating the public regarding the services that are available to them. There's a question around the directory of services. So is it up to date for all services and provisions available? As this is key for service providers to signpost patients to the right place.
So the directory of services is a very dynamic service understanding, so that if, for instance, people ring 111, 111 can see where there is available slots or appointments, and will ideally be able to pop people into the right place. But there are also these other navigation services which are being gradually built behind the scenes, so that if, for instance, patients have rung 999 but they don't need a 999 ambulance provision, they could well be directed through that service to an urgent treatment centre or to some other setting. So the directory of services can be opened and shut on a day-by-day basis in some cases. If, for instance, there is a complete reduction in the amount of staff in a particular UTC, or they're overburdened by patients, you may close down the directory service for some hours or 2 or 3 hours to allow there to be better flow in that bit of the system. So it is kept up to date, and the hope is that the directory of service will become more all-embracing, particularly once you've got navigation hubs that are working in neighbourhoods and in localities. And so again, this is part of the broader sweep of work to try and build up community services, community resilience and neighbourhood work, and it will take time, but the thinking is going on within the ICB about how you try and deliver that to make service provision more accessible and more effective.
Thank you, Paul. There is a question in the chat around, are public health involved in this review?
I don't want to hog the line, but yes, they are. So we've had useful conversations with public health, who particularly informed us about population growth. And I think we may need to do probably a bit more work about the nature of that population growth in terms of its impact in specific places. And I think that may be part of the next phase. So going just from crude numbers to the type of population, i.e. age, frailty, and the way in which different populations access services differently. So how people who are young families moving into a new estate might look for different sorts of access to folk as they become older or frailer. So I think it's a kind of it needs to be quite nuanced, really. John, you've got your hand up.
Yeah, I was wondering about the tertiary sector, the VCSE. There are people that have taken part in collaborative meetings and so on, who aren't part in that sense of the formal system of healthcare, but they're involving people who've got a lot of experience, the sort of experts by experience. And I appreciate, obviously, in all the range of things that you're taking into account and bodies that you are accessing, whether those organisations really come into the frame, and is there a system or a mechanism by which that can be looked at?
So I think the voluntary service community colleagues are, I think, the unsung heroes in the whole of the system, actually, and provide an awful lot of value and benefit to localities and neighbourhoods. And in some sense, some of the work that we're doing here does not relate to that, but in the broader sense, they are part of the place conversation. So we've talked about the 8 places in Derbyshire, and we've also talked a bit about locality or neighbourhood services. And for those neighbourhoods to really work well, you're going to need close involvement with the voluntary services in those areas. So those services can sometimes be very helpful in terms of supporting discharge, of helping with different levels of care for people in the community. And I think so they are connected into different bits of the work, but more on the sort of what's called the place side of things. We're specifically dealing with the sort of same day emergency urgent care.
Thank you, Paul. There is
Yeah, thank you. Thank you.
Thank you, John. There's a statement in the Slido chat around, is the plan to centralise services on 2 cities and hope patients travel from rural areas just go to other counties? I think it'd be really helpful to clear that up.
Certainly not. You know, the issue is about access, and for some people, if you're on the edge of the county, it makes absolute sense to access a service outside of the county, and that's your right, and it's perfectly reasonable. It makes sense because the services may only be a mile down the road in Nottinghamshire or in Sheffield or you know, Glossop or wherever. So I think that there's not a driven intent to just sort of localize services in the two cities. That's not the intent at all. We've got very different populations and places in Derbyshire, and the whole point of this is to try and understand what we've got and what we can do better. So there are some places where you've got, you know, a complex population like in the city of Derby, where there's a lot of different populations with different ethnic backgrounds, different times at which they've emerged into the population of Derby, who access care differently. And so we have a community UTC in Derby City, and it sits in a part of the town of the city where it's close to quite a lot of those populations who access care at a higher rate than some other populations. But we've also got to think about populations that are in rural parts of Derbyshire, and where do they go? And that doesn't mean you know that you're expected to drive or find a friend who's got a car. A lot of that goes on, but we've got to be cognizant of what does access really mean. So you know, we've got a UTC in Buxton. We're aware of issues in Bolsover and North East Derbyshire. We're aware of issues in Swaddling Coat and South Derbyshire. And it's really about trying to, in the first instance, aggregate what current resources there are, because there are parts of the services in Derbyshire where there's a lot of different services, often working from the same building, slightly different hours, not sharing their staff, and almost tripping over each other, and that doesn't make sense. So we've got some of that going on, for instance, in Ilkeston. So we have to think about this more you know, in the broadest sense. But no, the intention is not to just try and centralize it. The intention is to try and look at each place and make the services as robust and resilient and as effective as possible in each of those places.
Thank you. There's a comment and question in the chat around why GP practices are unable to access DOS, and just want to say thank you to Ruth Batt and Hannah Simmons that have responded to that and will provide sort of further information on that. So I think that's really helpful. There's also been a number of calls across the Slido and the chat around involving LMC, who can share information to a wider audience. So I think that's just an ask in terms of that.
Yes, no, that's perfectly reasonable. We've had conversations with the LMC in the early part of the work, and we're very much working and have involvement from the GP provider board in the discussions, and they are part of the ongoing working group around it. So there is close alignment with the GPs, and there's also close alignment with what's called the primary care strategy in Derbyshire, which is trying to kind of provide an understanding of how best to provide care for patients that are part of each general practice, and it's having these different cohorts of patients, some who I sort of spoke about earlier, who are relatively straightforward but just need something today, tomorrow, and who's the best person to pick that care up. And then where GPs and the associated teams are likely to need to focus for the long term is going to be on complex patients who have got multiple medical problems, complex frailty, disability, end of life, and need to work and focus on those cares, because that's where you improve the outcomes for those patients. But equally, the outcomes for other patients who need something sorted on a same day should be attended to, and we're going to need to have a symphony of supporting partners to make that happen in each neighbourhood. And so that's what we're trying to link the neighbourhoods, but also link very closely with general practice, because as I said right at the beginning, the bulk of same-day care is actually occurring in your GP practice.
Thank you. There was a comment a while ago as well in Slido, so thank you, about please link in with the LNH work currently in progress. So these are the local navigation hubs that Paul has referred to previously. And I think Rachel and Paul would agree that we are integrated and involved as part of those conversations on a daily basis. So yeah,
Live and breathe them, I've got to say.
We do, yes.
Okay. We have got a bit more time, but we don't need to use all the time. I can see some folk have dropped off the call as well. So in terms of, I don't know if we sort of draw things to a conclusion at this point. We're really, first of all, grateful for your time, because you've chosen to spend time on the call, and you've spent time listening and asking questions and responding to the Slido. And we want you to know that we will be looking at those thoughts and questions that you have raised. We'll try and put them in themes. We'll try and understand them in the context of the thinking we're applying to this project. And I have no doubt that we will definitely be meeting up in this form or some other form over the lifetime of this project. So please know the Slido is still open. Please feel free to raise your comments and further questions through the urgent care link that was sent out by Hannah. And please be aware that we are listening and thoughtful about concerns, and our intention is to try and improve and make services more accessible and more resilient. So unless there's anything else anybody else wants to say, that's really all I've got to say at the moment. But I don't know if Hannah or Rachel wants to come in at this stage.
Thanks, Paul. Just to echo what you've said, and thank you to everybody for taking the time this morning. It's been really helpful, and we'll be in touch.
We will. And I just wanted to also add, I noticed in the chat box around the presentation from today, and I know Rachel's already touched on it, but I will send an email around later and I will attach the slides to that. So thank you everybody for joining this morning.
Thank you very much indeed. Been really good.
Thanks, Jan.